All right. I say got it here. Got it.
No.
Okay. Um, okay. First of all, thank you for inviting me to talk on this topic, pulmonary arterial hypertension. My name is Salamber Suba, and I'm one of the pulmonary doc. Um, and Joel Watt, is my mentor, and he retired and primarily doing the PH work right now with my partner, Dan Bolonowski. Let's see. The disclosure, I have no disclosure. The objectives for today's talk is really mostly, I want to go over nuts and bolts of the PAH management. So as to say, what are the drugs and why we do what we do and how we do. I think that's the main objectives of today's talk. But got to understand what pulmonary hypertension versus pulmonary arterial hypertension. So, that differentiation is really the key because the accurate diagnosis is the key. So I'll spend first several slides to highlight that. And I'll also briefly go over our joint collaborative program with the heart failure team. This has been one of our clinical transformation project for this year, and it's going strong. First of all, this joint programs would look something like this. It will be both outpatient and inpatient. We'll designate who would be the program MDs and APPs who will be seeing these patients. We haven't ironed out the exact details on how the outpatient and inpatient is going to be like. But this is how roughly it looks like. We're thinking about 2 half days clinic a week for this, and it'll be combined with complex dyspnea cases. So it will be combined pulmonary hypertension and complex dyspnea program. And these patients, depending on the situations, comes in inpatient, both suspected PAH patients and known PAH patient, just to initiate on intravenous therapy or to expedite the workup. And we did have few cases inpatient for last few months as a pilot trial. I just want to see how that goes, and we have lot of things to learn from that. It was a very enriching experience for all of us. Obviously, when the new program goes in, there'll be a lot of confusions, the usual natural course, but we got a lot of positive feedbacks from both APPs and CAPs and docs. So a lot to learn from there. Now, just getting into the topic, why pulmonary hypertension matters, right? So it matters because it affects a right ventricle, and hence why the cardiology need to be involved, and your role would be very important here. In pulmonary arterial hypertension, the major outcomes, patient outcomes at the end of the day is really depends on how the right ventricle is functioning. And this slide briefly goes over that. On the panel A on my left side, as you guys all know, how our right ventricle is less muscular than the left ventricle, and not uh, cope with uh, adequate coping mechanisms, adaptive mechanisms to deal with increased resistance as compared to the left ventricle. On the panel B, this is the famous uh, dog model studies from 1960s, which great Dr. Brownwald described in his classic test book. Here you can see how sensitive the right ventricle is with the increase in afterload. Even with the small increase in pressure or afterload, the right ventricle stroke volume drops very drastically as compared to left ventricle, which can cope up with that kind of increase in afterload. It's really a neat experiment in a dog that was shown here. So overall, the gist is, right ventricle is a low pressure but high flow pump system, and it's connected to a pulmonary vascular circuit, which is a very low resistant circuit. What is pulmonary arterial hypertension, right? So that's the crux of the matter here. It's a progressive fatal disease, and it's driven by pulmonary vascular remodeling. In this cartoon, as you can see on the left side, that's the normal pulmonary artery, and how fine finally there's a balance between pro-proliferative vascular constrictors um, uh, with anti-proliferative vasodilators, right? So that need to have a pretty fine vascular homeostasis for the normal functioning. Now, as we lose that homeostasis as a result of, things that's happening in the uh, uh, different layers of a pulmonary artery, we see this luminal narrowing of the pulmonary arteries, and hence the problem here. To highlight that furthermore, if you zoom out that pulmonary artery, this is what's happening on the left side. It's a normal pulmonary artery. All three layers, you can see that, endothelium and tunica media, which is the middle layer, and outside layer, adventitia. Um, Now, all these three layers is affected in pulmonary arterial hypertension. Now, this is very, very important slides. As you can see here, as the endothelial layers gets affected, this is where all our pulmonary vasodilators um, gets released. The release of that gets affected, and in the media there will be smooth muscle hyperplasia, hypertrophy, and in the advanced layer, there's a lot of matrix deposition, scarring, fibrosis happening. The inflammations. This is all happening. Now, this is very important to understand because in the past, the belief system for pulmonary arterial hypertension, the pathophysiology of it was believed to be just the vasoconstriction uh, of the pulmonary artery and the in situ thrombosis in the luminal. But there's a major paradigm shift currently with all the molecular understanding of the PAH that now we know that it's not just the pulmonary vasoconstriction and the thrombosis. It's beyond that. There's the vascular cells, inflammations and growth, involvement of cytokines, growth factors, all these factors. Why this is important is, there are several drugs in pipeline that's going to come in the future targeting for those molecules. More to come in the near future, which I'm going to go briefly with particular one of them called sotatercept at the end of slide, somewhere in the slide. Now, this is what's happening in the endothelial layer, which is inner layer of the pulmonary artery, and that's how our drugs current drugs are based on. So basically, in pulmonary arterial hypertension, there's a overexpression of endothelin pathway and underexpression of nitric oxide pathway and prostacyclin pathway. Now remember, endothelin is a potent vasoconstrictor, whereas nitric oxide and prostacyclin are the vasodilators. Now, why that matters? Now, this is really important slides, right? Because to differentiate between pulmonary hypertension, which is the umbrella term, from pulmonary arterial hypertension is the key here. You know, as you can see in this slide, anything, this is just a hemodynamic definition. So take this with a little grain of salt. This is, cutoffs are important, definitions are important, but this is, the way I take this is more of a concept building slide here. Hemodynamically, for mean pulmonary artery pressure, greater than 20 is pulmonary hypertension, and you add wedge pressure, pulmonary arterial occlusion pressure less than 15 with pulmonary vascular resistance greater than 2 Wood units, that is pulmonary arterial hypertension. What it's trying to tell is, you should not have left side heart disease as a cause for increasing pulmonary pressure. Now, several things here. First of all, this is the new updated definitions. For last 60 years, definition for pulmonary hypertension has been greater than mean pulmonary artery pressure greater than 25. And in the recent, not so recent, about 4 or 5 years ago, 2018, WSPH has updated that criteria, dropped that PA pressure from mean PA pressure from 25 to 20. The PVR, pulmonary vascular resistance, they dropped from 3 Wood unit to 2 Wood unit just last year by European Society. Now, the important thing here is, these things are changing, these criteria cutoffs are changing, but our drugs that we have about 14 FDA approved drugs. These drugs are still based on old criteria, which is mean PA pressure greater than 25 and PVR greater than 3 Wood unit. And I don't think anybody have much clarity as to are we gonna start our patient based on this criteria. These criteria is based more for hemodynamic characterization, not necessarily to start somebody on treatment. It should be case by case. Very important point there. And by this slide, I also want to highlight the fact that pulmonary vascular resistance is a calculated measure. It's a calculated index. It's not the measured one, as shown on the right-hand panel. That the formula is pressure on the right side minus pressure on the left side divided by cardiac output. Why that is important is, once we have calculated metrics, there are more room for error. So yeah, we have to make sure where these numbers are coming from, what kind of a cath lab it's coming from, and what is the quality of that cath lab. Everything matters here. This is just the cartoon to highlight the different clinical classification of different type of pulmonary hypertension. And very nicely in one slide, it speaks, it highlights the different types of pulmonary hypertension. Because we throw out several terms here and can be sometimes confusing, like pre-cap, post-cap, combined, and so forth. And with this slide, as you can see, precapillary pulmonary hypertension is the one that we are talking about, which is a pulmonary arterial hypertension. And you see that's a WHO classification group 1. And postcapillary, which is pulmonary venous hypertension, which is WHO group classification 2. And as you can see there, the pulmonary capillaries being involved, which is lung problem or hypoxia, WHO group classification 3, and 4 is really the chronic clot, obstructing the pulmonary arteries, which is WHO classification group 4. And there's another one, group 5, which is a mixed bag of all. And this is the most recent, 2018 World Symposium on Pulmonary Hypertension classification, and it's the most updated one. And World Symposium on Pulmonary Hypertension. This is like an international group who meets every 4 or 5 years internationally, and they decide on different aspects of pulmonary arterial hypertension. Now I won't go over the every aspects of it, and we're gonna focus more on group 1, and this is very important here. All the drugs, pulmonary vasodilators, and PAH specific drugs that we have now is more it's focused on group 1 PAH. Very important to understand that. There are some exceptions there though. In terms of the breakdown of those the pulmonary hypertension different groups, this is the real world scenario though, right? Group 1 PAH is a rare disease. As you can see, the prevalence is really 1 to 2 per 100,000 population. It's pretty rare. The fact of the matter, the most common cause is group 2, which is left heart disease, and group 3, which is lung disease, right? As you can see here in the slide pie chart, nicely shown here. Group 1 is not that common, and this is basically the one on the center. The pie chart is basically this is the patient population breakdown from one of the Western Australian community, and this is true for everywhere across the country. So this is very important that most of the pulmonary hypertension. Now remember, I'm saying pulmonary hypertension, not pulmonary arterial hypertension. Most of the pulmonary hypertension you're going to see out there, it's mostly group 2 followed by group 3. Now, in terms of group 1 pulmonary arterial hypertension, this is how the breakdown looks like. And this is the breakdown from one of the largest PAH registry. This is our US registry, and the largest one have about more than 2,000 patient population. And in that patient populations, almost close to half of them were idiopathic pulmonary arterial hypertension, and half of that are associated PAH. Only small patient population are hereditary or familial pulmonary arterial hypertension. Among associated PAH, almost half here in this registry are connective tissue disease, and specifically in connective tissue disease, scleroderma is the key, most important one. Scleroderma and mixed connective tissue disease are the two most important connective tissue disease. In our one local experience here, we have about 150 PAH patient. About 2/3 of
Thank you.
our patients are connective tissue disease. Excuse me, you hear me okay? Andrea, you hear me okay?
Yeah, we hear
Okay.
you.
Yes, I hear you. Okay.
Okay. So about 2/3 of the patients in our group is connective tissue disease, and rest is the breakdown. As you can see there, drugs and toxins are there. Advanced liver disease associated PAH gets into group 1 too. HIV, congenital heart disease, these are other groups. Now, important to know that there are other causes that can cause pulmonary arterial hypertension, and that gets to the group 1, not just the idiopathic. Almost half of them are associated PAH, and it can be diagnostic dilemma early on because it can mimic a lot of clinical pictures there. This is briefly to go over the importance of hemodynamics and clinical course. A lot lot of times when we see our patients, they are like advanced, because these symptoms are very PH symptoms, very non-specific, and by the time they get our attention, they are advanced disease. And as this slide really the importance of the hemodynamic changes and the clinical course here. Um, um, the hemodynamics here. The cardiac output, pulmonary artery pressure, and pulmonary vascular resistance, how it changes along with the involvement of the pulmonary arteries restrictions here. The important point here in this graph, I would like to highlight is um, the pulmonary artery pressure increases up to certain point, and at one point, advanced state, your right ventricle simply give up and doesn't have that capacity to generate all the pressure. So the cardiac output drops, PA pressure drops, which is only a sign. This is important to know that, not just to hang the head on PA pressure. If the right ventricle is compensating okay, pulmonary pressure, even though it's high, it really doesn't matter. It matters when it starts decompensating. So just not to look at the pressure, and the the function is what matters here. This is briefly the clinical course, how it's, once the pressure in the pulmonary circulation goes up, increase work for right ventricle and decrease oxygenated blood in the lung, and causes hypoxia and other arm, right heart strain, as and then the right heart failure. And so these are the symptoms that you see, the right heart failure symptoms that unexamine the symptoms. And, this is important. When we see patients suspected PAS with advanced disease with breathing based on right heart failure, if we see these symptoms, these are the group of patients that we want to bring in to expedite the workup and to initiate the therapy, as opposed to, following them in the clinic. So this is very important point. A second important point on this slide is hypoxia and pulmonary arterial hypertension. It's never severe. It's only mild to moderate. If there's a severe hypoxia, somebody you're looking at high flow, or on BiPAP, you're dealing with something else. It's not pulmonary arterial hypertension. Very important point to make it there. Just a little bit of epidemiology here. It's a female preponderance disease. Mean age is 50 years, plus minus 15 years. Time to diagnosis was still delayed because of the delayed referral, about 1.5 to 2 years. This is we need to shorten this timeline, because advanced disease, it's hard to catch up the disease even with our therapy, and they carry poor prognosis. The reason for that delay is really all these non-specific symptoms, and syncopal episodes, exertional chest pain, dizziness, evidence of RV failure, right ventricle failure. These are the red flag signs here. The prognosis, right? This is the NIH registry from 1980s, multi-center. This is before any PH specific drugs. This is almost like a cancer, right? Back in the days when median survival is 2.8 years, as you can see here, things have improved now with the current therapy. This is a contemporary prognosis, but not to our satisfaction still. Median survival is about 7 years. And in my humble opinion, this is mostly because a lot of disease we catch is an advanced disease. And it's hard to catch up. So really to make more progress on this field, early referral is the key here still. And the diagnosis is really echocardiogram is the gold standard screening, and right heart catheter with a vasodilator test is a confirmatory one. In the future, cardiac MRI and exercise echo is coming. I'm gonna go a little bit fast here.
We do have some outpatient APPs on here too, so I don't know if we want to touch upon like some of the things that they can help with expediting diagnoses as well.
Perfect. And that's where we at right now.
Okay, sorry.
Yeah, the diagnostic approach, right? So we know echocardiogram is a gold standard screening test here, uh, but you need to have a kind of a understanding of what the disease is, because as you know, group 2 and 3 is really the common disease, and a lot of time I see people explaining their symptoms and echocardiographic findings uh, on other things, right? Like mainly left-sided heart disease and lung disease. And we spend a lot of time explaining all that, which in fact that might be true, but I see we find a reason to not refer them based on our one explanation using our both, our type 1, type 2 clinical thinking there. And, I think mostly that comes from because, we are jumping the gun, getting into echocardiogram first of all, so that's why I think this slide kind of goes over the brings the clarity and go over, the importance of echocardiogram, but, not to jump the gun, right? It's this slide showing, the lung disease and the chronic clot and left-sided heart disease, and based on, the initial gestalt, obviously gestalt is it's important clinical opinion, you need to go through the process before you actually get the echocardiogram. Again, you guys, get the echocardiogram up front, and you have reason to get the echocardiogram up front. That's true. That's right. But in the same, at the same time, for example, you get echocardiogram, looks very abnormal, and it's you think this is out of proportion, then and you're obviously going to refer and not to like just delay the referral, but at the same time, um, to get the ball rolling, you can order some of those tests that's on the screen here, depending on what you think, like see, oftentimes when I get referral, just I have barely one echocardiogram, and that's like not all the time. That's like 5 months ago or like a year ago, sometimes even, I'm trying to sound dramatic here, but that's true. I have a few cases like that, not even a chest x-ray, and so forth. So, uh, the process, the order which we get these tests are also very important. That's the point that I'm trying to make here. And now, in terms of echocardiogram, it's very important. This is this is a famous figure 4 on the recent updated guideline now, which talks about the measurement of RV on echocardiogram, because everybody, not everybody, most of us, we just hang our head on RVSP, which is the OPA pressure. But again, as I said, if our right ventricle is compensating with increased pressure, you know, yeah, it's a different scenario than if it's not compensating. So what I'm trying to say is there are other RV metrics that's are even more important than the pressure, RVSP. And RVSP is, as you can say here, it's a simple Bernoulli equation viewing a peak tricuspid valve, regurgitation, and it's a calculated one again. It's a lot of room for error, if you make a small error in measuring that tricuspid valve regurgitation, you're multiplying that, squaring by 2 and multiplying that by 4. So that's a lot of big error. So, focus also more on, how the right ventricle looks like, how the right atrium looks like. Is it dilated? What's the function of the right ventricle? And this figure highlights just that, At the end of the day, pulmonary hypertension by echocardiogram is not equivalent to pulmonary arterial hypertension. Very important point here. And obviously the right heart catheterization is the gold standard test. And not just to diagnose, to exclude the other diseases, valvular disease, shunt, it's important there. And we sometimes, we repeat it for therapeutic response. And as we know, we want to know the hemodynamics. It predicts the survival. And the important thing is vasodilator challenge protocol, right? So this is very important. And I see a lot of not a lot of, but some, sometimes I see a lot of confusion there, as of, who needs this kind of a challenge, and does all of them need it? Um, the guideline does not suggest to get the pulmonary vascular challenge test with all the right heart cath. The indications really for idiopathic pulmonary arterial hypertension, heritable, and drug induced. Beyond that, we really don't need it. Uh, and the prerequisite should be, you should not have left-sided heart disease, right? Meaning your pulmonary capillary wedge pressure should be less than 15 before you even do a vasodilator challenge test. Otherwise, there's no point. They go into, increase pulmonary edema there. And the agent that we use is inhaled nitric oxide, 40 parts per million for 5 minutes. And this is the recommendation from the guideline. I still see, people using, um, uh, epoprostenol and not other vasodilator agent other than inhaled nitric oxide. Those are not recommended at all. I think we should stick with the inhaled nitric oxide. And responders are defined as drop in mean PA pressure uh, by 10 point with mean pulmonary artery pressure less than 40, and there should be no drop in cardiac output at all. And this group has a good prognosis, right? 95% 5-year survival, and they can be treated with simple calcium channel blockers. Often a few points here. I hear sometimes the skepticism that, well, we have better drugs than just the calcium channel blockers, so why we should do a vasodilator challenge test. Well, 2 points on that is, one, it portends prognosis, good prognosis. Number two, we are in a state of Maine. A lot of our patients are from north, right? Um, Drugs can be pH drugs are very expensive, right? So who knows? Those Some of those patients just need monotherapy with calcium channel blockers. We have few patients who did well with just the calcium channel blockers. That's important. The other important point here in performing a vasodilator challenge test is, one, when while you're doing a test, if the wedge pressure is more than 15, obviously you won't do it. Secondly, if your mean pressure is less than 40, why even you want to bother with dilator challenge test, right? So these are some of the practical things, and our intervention cardiologist, it's very well versed with all these things. But these are the things that we also need to have clarity here. Um, the why vasodilator testing is important, right? This is the two landmark studies um, for to highlight the importance of um, vasodilator test. There, the one on my left hand side, the left panel is by Dr. Stewart in University of Illinois, that he did back in the 80s study. This is the landmark study. And as you can see here, on the red dot, who responded really well, their survival they is pretty good, and those who did not, their survival is pretty bad, as you can see here. And on the right hand side, the same thing was reproduced by this group in France, Paris group. They looked into the difference between the long-term cancer channel responder and the non-long-term calcium channel blocker responders, and those with those criteria, meeting those criteria with drop in 10 point by less than 40, and no drop in cardiac output, they benefit prolonged survival benefit, as you can see. And for acute responder, not meeting those criteria, sometimes we say this group as a partial responder group, and as you can see, their survival got much worse, and shortly after. So this is important. There's nothing like partial responder. I mean, it's either meeting that criteria or not. And this study highlights really nicely here. Really going over the management. Wow, 7:40 already. Going over the management here, goals of therapy. What we need to do is really, to improve the exercise capacity. Prevention of clinical worsening, improve quality of life, and improve survival. And how we do that, how we measure that is by a functional class, New York Heart Association functional class. And goal is to really to achieve 1 to 2. And you guys are well versed with this classification. We do 6-minute walk distance, every visit. And to achieve that goal more than 380 at least. And on echo, the goal is to see normalize some right ventricle size and function. And there's a role of BNP. We want to get it down to 2-digit number and improve the hemodynamics, right? um so so the so that's how we do that is, by risk multi-parametric risk stratification tool. The one on the left side with the color is the European classification system, and on the right is a famous reveal risk stratification tool. You can choose whichever you want, and you don't need to remember all this. You have a nice med calc calculator, and we are also trying to put this in Epic so that we don't have to memorize it. The crux is here is, these are multi-parametric risk stratification tool, and we do it at baseline in every follow-up visit. And as you can see, it matters because the high risk portends, increase 1 year mortality risk, right, greater than 10%. The key here really is to achieve and maintain the low risk status with the treatment. And this is some of the ways that we measure our disease. And 6-minute walk distance I mentioned. As you can see here, these are original study, late 1990s studies when we only have IV intravenous epoprostenol therapy. And these are the studies done in that group, like the 6-minute walk distance on my left hand top panel is a study from Japan. As you can see, those folks who can walk more, um, have a better prognosis than less. And the distance of 332 meters, that's not a magic number, it's a concept that you have to understand. But anyhow, our goal is to try to reach more than 380 meter at least if we can. And the bottom panel diagram is a functional class a diagram there. This is Dr. McLaughlin's University of Michigan study, and these are also the patient on IV proprostanol. As you can see here, those folks who are on IV proportional therapy for a year, as you can see that 12 months, a year, and even after a year of IV proportional, if their functional class does not improve, they have a very poor prognosis. These are the group that you're thinking about, lung transplant and so forth in right clinical setting. On the right hand side, the role of BNP, again, this is folks on IV proportional or oral therapy now, and it highlights the role of the BNP. Uh, Higher BNP, at baseline, increases the risk fold, increase of risk of dying, 12-fold risk of dying at baseline if the BNP is high, and at follow-up if it's high, that you have 25-fold risk of dying. So the goal is to keep the BNP or NT-proBNP to 2-digit number. Obviously, I hear a little bit of a skepticism from people. BNP, is a lot of confounders there. Obviously, yes, renally clear there are, but you got to judiciously interpret the data. It's well validated tool, objective tool that we use, so we should follow that. before talking about the drugs, I think we need to briefly know about, what these drugs are really aiming for. Now, these drugs talks about the clinical endpoint in different PH drugs. As you can see here in the past, we were our primary outcomes were 6-minute walk distance, quality of life, and now we are more into hard clinical outcome like mortality and morbidity, time to clinical worsening, and you can see this in the current new drug trials. These are larger and longer trials as opposed to smaller, shorter duration trial in the past, because in the past didn't have a lot of drug therapy and people were dying fast, and we are working on war footing back then. Um, uh, the Now talking about the PH drugs, these are non-specific PS therapies, right? Calcium channel blocker, diuretics, oxygen, digoxin, anticoagulant. In the past, before pH specific drugs, everybody would be on these drugs. But now, as you know, those who are calcium channel responders would be on calcium channel blocker. Not everybody would be on anticoagulants. The digoxin I want to highlight here is, we like to use digoxin in our patient group, um, because it, even without, atrial arrhythmias, because it has unique additional benefit of, RV contractility. So we're just looking for a reason to start them on digoxin, um, a low threshold to start them on these oxygens in the right clinical setting. Now, this is the pH specific drugs with the timeline here, and we came a long way, right? But still newest, right? 25 years of history still with the pH drug, and so far 14 FDA approved drugs here. Going over this slide, the first description, real clinical description of PAH came from Brooklyn, U.S. In 1950, based on case series, right? New York City. And then a prostacyclin molecule was identified mid 1970s. Calcium channel blockers were approved in 1980s after Dr. Rich Stewart's University of Illinois study there. Epoprostenol was approved in 1995 after the study, which I'm going to go over in a minute. And in that study, our main medical center was site. So we were doing this for some time now. And then, the or other oral drugs approved after that. If you can see closely here, and pay attention. These are drugs for group 1 PAH. The exception here is the one on the red here. It's Tyvaso, which is inhaled prostacyclin analog drugs called Remazulin, and this is approved for group 3. That is ILD or lung disease related PAH. Group 3, and it's approved, FDA approved. And then there are several other drugs in a pipeline here, as shown here. The sotatercept is the one that I'm going to talk about because it's going to be approved early next year. Very outstanding recent data there. So going back to the same slide, before understanding the drugs, we got to understand these three pathways, and our best drugs are based on these pathways, right? So what these drugs do is it suppress the endothelin pathway, and so we have drugs on that, and the drugs to increase the nitric oxide and prostacyclins, and we have the drugs on that, and our 14 FDA approved drugs are based on these three pathways there. To talk about drugs, prostacyclin drugs, these are different forms of prostacyclin. It comes in IV form, which is called epoprostenol, or Flolan, Velitri, or treprostinil, Remazulin. I'll go over that, what that means. And the subcutaneous treprostinil form, and it forms in the inhaled form called Tyvaso. in Europe, there's something called iloprost. We don't use that. And the oral form, we call it. The names are a little hard to get it the first time, but you will get it. Selexipag and treprostinil, Uptravi or Onitram. So these are the different forms of drugs there. The basic difference between ibuprofen, treprostinil, and Tyvaso, these are prostacyclin drugs. The pharmacokinetics here. Everybody's familiar with ibuprofen or Flolan. We don't use Flolan anymore right now because it's very unstable at room temperature and need very careful attention, such that we have to ice pack it before we use it. So we use um, instead of Flolan, you use Velitri, which is very stable at room temperature. Again, ibuprofen advantage, it's very short half-life, less than 6 minutes. EG on, EG off. The side effects profiles are more because it's potent. Again, the IV is the route of administration. We usually start with 2 nanogram, and there's no ceiling dose for any of the IV therapies. Important to know that. Whereas treprostinil, which is also we also call it Remodulin, which is also a prostacyclin analog. Half-life is about 4 hours. We can use it either IV or subcutaneously. Same dosing pattern. Whereas Tyvaso, which is an inhaled form, is its half-life is about less than an hour, 30 minutes to 45 minutes, stable at room temperature. The downside to it is we use it 4 times daily. With the iloprost, which is another inhaled prostacyclin, you have to use up to 9 times. So a lot of the patient compliance obviously won't be that great with that many use. Just going briefly over the landmark trial of ibuprofen. As you can see here, this is a blinded randomized controlled trial from back in 1990s. And again, Maine Medical Center was one of the site for this study. And this is a short 12-week period of the time, right? A group got Centraline and ibuprofen, Flolan. The other group, obviously because of the nature of this design, you can't give them a Centraline, so it was not blinded and not controlled. The other group was conventional with other non-pH specific therapy. Now, the outcome, is, within 12 weeks, 8 patients died on folks who were not getting ibuprofen, and nobody died from whoever who got the ibuprofen there. And, it met several other secondary outcomes there. And, the downside to this is, again, the central line placement and the side effects coming from there. And it's a big commitment. And that, before I talk about subcutaneous, let's talk a little bit more about the nut and bolts on the Velitri, the nut and bolts on IV proportional therapy. And this is how it looks like. It needs central line Hickman catheter, which goes in. This is continuous infusion. And the pump that we use currently is what we call a CAT legacy pump, but that's changing, right? Soon instead of a legacy CAT pump, it will be replaced by something called Solaris pump. It's not yet in the market, but it's gonna be soon. This will be replacing old CAT legacy pump, and this is kind of a setup for starting somebody on Velitri or prostanol there. And somebody who are getting on this therapy, they need lots of education, and the educator, nurse educator from outside vendor comes, and these are only can be done inpatient. So these educator will come inpatient to teach our patient, and they need several sessions. Patients usually need a training buddy just for the backup. And the process is not slow. There are a lot of things that goes into, and it's It's slow process. It's not fast. Um, the central line types, there's a specific type of central line that need to go on, and so that's very important because this is continuous infusion. So the the point that I want to highlight here is the central line has to be soft, not the one that's made of hard material, because it tends to kink and crack. We have a few cases of that, because their life depends on this, so it's very important to be on that. And these are some of the ways to troubleshoot it. If there's any problem uh, with the catheter. The other important point here is, it can be prostanoid infusion can be given through the peripheral lines up to 4 to 5 hours, but not beyond that. And because remember, to minimize the bloodstream infection, these drugs are mixed with alkaline solution, so they have very high pH. So it's very caustic to the peripheral vein. So beyond 4 to 5 hours is not recommended at all. This is briefly the steps of mixing the intravenous, and patient does it. Most of our patient does it really well. It's just the initial course that they need to get well versed with. The needle, or needleless um, system with the syringes are there. It's just simple. You mix it, and we give them a dosing set, and depending on what's the dose and what's the frequency, they mix it and they can handle this all. Uh, but
I
this,
know we're running out of time,
yeah,
but I am curious, and I think my colleague Liz is still on here, and sorry to interrupt, but
yeah,
um, when it when it comes to initiating these medications, like what resources do we have with aiding in the discharges and making sure, because we're not our cardiac APP groups, um, this this is very specialized.
yeah,
So I would just kind of, if you could just speak on that too before we end up
yeah,
ending. And I
yeah.
understand we'll
So
go over.
yeah. So briefly, you mean resources are this is you mean in terms of education to the patient?
To help the APPs with the discharging, with when
Right.
they have these
So
medications,
I
like
think,
who orders them? Is there a care manager that can help with that? I don't know what Liz, did you have something? Are you still on, Liz?
I am. I'm here. Yeah, it was just,
right,
I mean, partially because it was a Saturday, but I had to discharge a patient who was new to, I think, treprostinil, whatever.
yeah.
And there's many steps and kind of specific things we have to do. And I was just wondering if somehow we could get some more information just to make the discharge process a little more
Yeah.
efficient for us and make sure we don't miss anything.
Absolutely. No, no, that's really good questions, right? So, typically how it's done is, I don't think care coordinators are well versed on this. This is the first of the drug is being ordered by either pulmonary or heart failure doc, whoever's on, who is well versed with the drug. Uh, but I think the confusion, with our experience with last few cases, came from lack of communication. The 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 educator, the outside vendor educator, their role is the key here. Um, and we should be in very close contact with them. They get the drug, they ask us to, whatever drug, whatever the strength, how much drug they are on inpatient, they're gonna go home on that, and they're gonna ask for all these drug and referral process. The referral process for now is through the chest medicine right now, but we're working on that just to make it more transparent. But I think most of the confusion came from lack of communication from that vendor, outside vendor. And I'm gonna touch, I'm planning to touch a little bit that at the end. But anyhow, we use, specialty pharmacy vendor. A Credo is the specific one for the New England, and there are not many. There are a handful of educator who handle not, this part of the New England, Boston, Maine, New Hampshire, Vermont, so they are kind of busy too. We have to give them ahead of time. One thing that we didn't do well, I think, with our experience with the recent cases is we did not loop all of them with that educator. And he would come in, and he or she would come in and would do the education and whatever needs to be done. And then rest of the folks, we didn't know what's going on. The usual process before was, what they do is once they educate, they reach out to us at chest medicine, and there's a APP and staff who receives that phone call and and disseminate that message to us, either me or Dan or whoever's involved, and that's how the message gets disseminated. And you can see here easily like how many steps in simple communication and things that can get confused and lost in translation here. And getting more into it, how other centers does it is, they communicate. Sadly, they only communicate through the email though, the vendor. So really, you know uh, you know the first thing in the morning, right, really trying to make sure that everybody in the team involved for that patient, we know it, and and try to connect that educator with all the team members, and they can give us the informations in the real time, like what they need. That that person would be the our best friend in terms of making the whole process smooth, because they will be working to get the drugs approved, and they will be the one who will be going to their home. They will be the one who will be taking calls from the patient if something goes wrong or this and that. So they will be committed to that patient, in a longitudinal fashion. So we need to be in touch. We need to come up with the system that we can be in touch with them in real time. Is I think the way to go from there. Did I answer your question?
Yeah, no, that was very helpful. And I think, yeah, maybe we can get a group of people together to develop some kind of protocol so we can improve communication. I did
Yeah,
meet the vendor educator person. His name, I think, is Charles Range.
yeah,
He
Chuck. Yeah,
came in. Yeah, Chuck. He came in that day. He was actually really helpful because he
yeah,
could see that I had no idea what I was doing.
of course.
But he helped me through the process. But yeah, I think we can make the process go a little bit smoother
Yeah,
in the future.
yeah. We're running out of time here. You know, uh, briefly, Andrea, do I have like 5 more minutes?
Yeah, go ahead. Yep.
Okay. So the IV, it comes with big commitment, central line infection. So there's a unique role for subcutaneous pump, right? And Remodulin, same drugs and same efficacy as you can see here. I'm not gonna go over much. We're gonna come back later on to talk about this. It's a really interesting stuff here. The pump looks something like this. The usually goes in the bottom or in an arm, or you know it can go in the thigh. Uh, you know it can be started at home. They don't need to come in a hospital for this, right? So this is advantage, and doesn't have bloodstream infections with this. And it comes with its one pros and cons here. And this is how the Remutu pump looks like. This is the newer version of pump. Everybody have this pump, but we still have some patients with the old insulin kind of a pump here. It's called CAD MS3, but this is phasing out. A lot of our patients you guys gonna see on this newer version Remutu pump. And it's the same principle: cassette, battery, and so forth. I have a real one. One of these sessions I will come back with these things to play with. And very steep learning curve. Easily can be understand. A lot of our patient, even old patients, they get it very fast. um this is a Tyvaso, how it looks like, the system. It's a ultrasonic nebulizer. It comes in a neb form or dry powder form, cartilage. A lot of folks, powder form is newer version, and a lot of our patients likes the powder form because it's easy, and this is the only one that we can use in group 3 pulmonary hypertensions, FDA approved, and different strength there. And as you can see, this is IV subcutaneous inhalation form there. Prostanoid side effects. We saw some of the extreme of the side effects from Remodulin and Velitree this time with one of our patients here. The usual side effects are really because of the vasodilatations. One. Number two, very important to understand. We know that prostaglandins are anti-inflammatory, but from our experience with the PADs, we've got the molecular study. It is not just anti-inflammatory. It can be pro-inflammatory, depending on the physiology, depending on the circumstances, and that's the reason why people can have delivery site complications, specifically for with the folks who use the pump subcutaneous pump. The most common side effects is infusion site inflammation and pain, and that's because of that. The prostanoid's really the drug causing the inflammation around the skin. It's more than 80% people have it, and that's the reason for that. One important neat fun fact with the prostanoid side effects is the jaw pain, first bite pain. Nobody knows why people have it, but they have this typical first bite pain, jaw pain, and then it goes away after they start eating. But doesn't bother. Once they are on it, they these symptoms gets better. The oral prostanoids drugs, it comes in a different color. These are only two different now drugs. Selexipag, Uptravi, it's twice a day. The strengths are there. And the second one is Orinatrem. Now remember, this is the same treprostinil, same Tyvaso, same Remodulin is the same drug, right? Different names. Don't get confused with the name. It comes with the different strains, and we titrate up as they tolerate it. Titrations can be a little confusing when they come in with these drugs, but the patients are well versed with. They come with the dosing sheet, and you'll know based on the color which color is, what strain they're on. Usually they know which strain. If not, they know the color. So knowing the color of the drugs are also very important. This is just the landmark studies based on those drugs. Griffin study, and that's how drugs get approved. I would like to come back to talk more about interesting fun facts about these trials. Nitric oxide pathway drugs, we have three: sildenafil and tadalafil, which is PD5 inhibitor, and stimulator of gonadotropin cyclase, which is riociguat. Names are a little tough to pronounce, but basically, for you to remember today is this this kitchen sink analogy that I have for you. Where your sildenafil and tadalafil is it blocks the drainage of the water. So that's the function of the PDE5 inhibitors. Whereas riociguat, it is the stimulator. It opens up your faucet. So and the bottom line is you want to increase that water. You want to increase that nitric oxide content in your sink. Which increases your cyclic guanosine monophosphate, which is basically what you want, to cause the relaxation of the vascular smooth muscle cell or other. And these are the studies, landmark studies, which get FDA approval for this. The important thing in this slide, you have to avoid the nitro compounds, right? No nitroglycerin, no MDR, nothing of that nature, and especially folks who have HIV, they cannot be on protease inhibitors there. Fun fact on side effects: some of the patient can have like all kind of visual disturbances. That's because of the PD5 is not just in the pulmonary arteries. They are also available in the retina of the eye, and it blocks that. So it causes, like, some of my patients have really weird visual symptoms. It goes away. The third drug is the endothelin pathway drug. It suppresses this. And again, endothelin is the most potent vasoconstrictor known to mankind. We use Opsumit or macitentan and ambrisentan. There's no drug titration to this. There's a once daily dose drugs. Bosentan, which is twice a day. We really use that drug because you have to monitor liver function tests every month. So really, it's only like out of 150 patients, only one of our patients have that. And the side effect profile, really the important one here is they have, it's very teratogenic. So somebody, woman with childbearing age, they need to be on double contraceptives pill. They need to sign the form, very, very important. And somebody in our ICU who needs the drugs need to be crossed. They need to always make sure that it's not childbearing woman, because it's very, very, even by crushing it, and if they're not cautious enough, even inhaling that powder, it can cause a lot of damage there. So I'll always be very careful, and they need to avoid over-the-counter drugs that contains uh, uh, phenylephrine and decongestant drugs there. And we usually combine these medicines in different form, from different class, and that comes from a landmark trial called Ambition trial. So oftentimes we start with two drugs, one from endothelin pathway, one from nitric oxide pathway. Um, um, and then at the last slide is sotatercept, which is a shot. And this is not yet FDA approved, but it's going to be next year, early next year for sure. This is a shot every 3 months, subcutaneous shot. Um, Pretty interesting pathway. This is the fourth pathway drug, just this is the 14 drugs is from those 3 cycle pathway drug. Now this is the fourth pathway. What it does, it brings that vascular homeostasis between antiproliferative and proliferative chemicals, and that's how it causes vasodilation and reverse the vascular remodeling. And in that risk stratification tool, even on maximal therapy, if their reveal risk score is greater than 7, if they're not doing better, right clinical setting, you're thinking about lung transplant referral there. Lastly, on CTAF, this is group 4, because of the chronic clot. About 3 to 4% of chronic acute PE will have this patient, will have CTAF. And these are surgical disease. We have to understand this. In the meantime, when they're in RV failure, we stabilize them with IV the therapy that we talked about. But really, this is in a right clinical setting, it's a surgical disease, and we are thinking about referring this patient to Boston inpatient where they're that bad, in RV failure with this disease. Logistic about the medications that I just talked about, for us, it's Accredo or CVS Caremark, and prostanide drugs, oral IV, and endothelin pathway drugs are taken care of by those two pharmacy, and sildenafil tadalafil usually comes from regular pharmacy. Summary, really need to differentiate between PAH from PH. Um, Targeted therapy, 14 FDA drugs is for group 1, exception being Tyvaso, which is group 3. And we got to understand why parenteral versus oral, single versus combination therapy, and how we measure the disease, and when we start thinking about the transplant referral. Very, very important. And the future direction is gonna need your help, guys. We're really planning to make this joint program, success. And the state of Maine needs it, right? We need a system in place, not a system which is person dependent. And really the goal is to make it PH care center to improve the patient outcome and to participate in clinical trial at some point. Now, this is our team. Huge applause to Dr. Joel Watt and Dr. Tom Ryan. These are the guys who were doing it for MenMed in the past, and it's because of them we're talking all about this, and this program exists still now. And thank you all, guys. Thank you so much.
Thank,
Yeah.
thank you.
Certainly.
I'll have you
Yeah.
send send your slides to me too, and then I'll
Sure.
send it, and then we'll probably have a separate talk too with
Yeah.
just our inpatient APPs and just more of like the logistics, like some of the things that came up with Liz, and those kinds of things. So anyway,
Okay.
yeah, send me your slides, Andrea Mosley, and that was great. Thank you.
Thanks. Take care now.
Okay, bye-bye.